Hello, everyone. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. Thank you for joining us again for the 10th week in our series of webinars on preventing and managing COVID-19 in the workplace. For those of you who are joining us for the first time, welcome, and we appreciate continued participation by those of you who have been with us these past 10 weeks. Today, Dr. Harris, our speaker, will be covering the trends that he always has covered in all previous sessions, and he's going to focus particularly today on providing reassurance at the doorstep of your business as we start to gear back up for return to work and supporting the essential workforce that has been present in the workplace this entire time. As you know, the session is being recorded, and we post the recording on our YouTube channel within about 24 hours. We also summarize the questions and answers that are submitted during the session, and we post those on our website. During the session, Alexis will post the links to both of those. And I'm just about to prepare to finalize a frequently asked questions document on testing, which you may find of interest, which will be posted on our website by tomorrow. During the webinar, please submit your questions using the Q&A function on Zoom. I'll be the monitor for the questions, and we'll ask them, and Dr. Harris will respond in the time that we have allowed. We usually conclude within 40 minutes. So any questions we don't get to, we'll be sure to summarize those in the written version. So let me introduce Dr. Harris, with whom you're familiar if you've attended previous sessions. Dr. Harris is an MD, MBA, MPH. He's a board-certified occupational medicine physician. And up until recently, his job title with WorkCare was Vice President of On-Site Clinical Services, On-Site Clinical Operations, and he's an Associate Medical Director. But I'm really excited to tell you today that he's now assumed the role of Chief Innovation Officer for WorkCare, so we can expect some really exciting things to come from Dr. Harris, as one of his interests is inventions. So we're sure to see some interesting developments from him. So now I'll turn it over to him. Thank you for joining us.
Excellent. Thank you, Karen, and thanks to everyone for joining us once again. We appreciate you taking time to stay informed and stay up to date with what's happening in regards to COVID and as it pertains to your business and to your employees. And today we're going to spend some time talking about how to help with the storefront and in regards to customer-facing businesses. We'll begin into that strategy that we are helping employers with as such. So we're going to really kick it into high gear this week. Format will be the same. We'll talk about any clinical updates in terms of presentations, the pathology, what we're seeing in terms of evolution of the virus and testing. We'll look at epidemiology and really focus in on is there an increased risk to your employees, to your patrons in regards to as the employee customer-facing fronts reopen. And then we'll talk about the strategies we've begun to assist with. If you've been joining us, hopefully you'll see some familiar strategies, and we'll reaffirm those and introduce some new strategies as well. So with that being said, let's jump into the clinical presentation updates. There are no significant leaps in terms of understandings regarding clinical presentation for this week at least. Obviously, the symptomatology to continue to pay attention to span beyond temperature screening, right? And so we know that temperature screening is still increasing in its frequency of use with employers, but we want to reemphasize that we should, at this point, be screening beyond just temperature and looking for a fever with these other clinical presentations. When we talk about then the microbiology or the pathology changes of recent, we see a couple headlines that point towards the employers' concern about testing of their employees, the workforce, but then how long should you be testing? And to that extent, there is evidence that is new as of this week, suggesting, and this comes out of Korea, suggesting and seeing a trend of individuals that are testing positive for coronavirus, COVID-19, far after their recovery. And we're talking weeks after their recovery. And what this study in particular is showing is that even though individuals are positive weeks later from a nasopharyngeal through the nose or oropharyngeal approach, looking at PCR, the individuals are not infectious. And the way they demonstrated that was trying to grow the virus in vitro. Weeks and weeks ago, we presented that to you as one of the ways we verify an individual may have immunity, is you are able to take a sample of their blood and their serum and actually inhibit the growth of virus in a petri dish of sorts. And so what this study looked at was if you isolate the virus from an individual that has recovered long ago from COVID-19, would that virus grow on its own without any inhibition? And the study concluded that many of these individuals presenting positive prolonged periods after their recovery are not able to grow virus in vitro. Right, so that's obviously good news in terms of transmissibility long after you've recovered, but it does pose a conundrum in terms of how do you then screen these individuals and identify them as such. And even parts of Korea has limited the requirement for a negative test, repeated negative test, as a result of this phenomenon. When we talk about other concerns in the marketplace with employers, there are increasing concerns about cleanliness, right? And not just normal hygienic cleanliness. We're talking a regimen of cleaning in the workplace that is above our quote unquote baseline, if you would, pre-COVID cleaning. And what studies have shown as well is that cleaning can and good hygiene can deeply impact the transmissibility and transmission of COVID-19 and other viruses in the workplace. This particular study looked at transmission in the workplace of one individual being infected, and I may have presented this if you were with us prior to today, but one individual being infected by a virus that is basically inactive, but they can still track it as a tracer. At the end of the day, what the study found was that an individual can transmit a virus to almost the entire workforce in a matter of just one 24-hour period and contaminate multiple surfaces, creating what's called fomites. And by just cleaning deep, and this is regular cleaning, offering hand hygiene with alcohol gels and solutions and such, you can reduce your transmission in the workplace by 85%. And so that's why you see an uptick in attention to cleaning in the workspaces. When we look at then and focus now on the epidemiology of, in particular, the U.S., we want to dive deep into the reopening of the U.S., right, and what is happening in terms of trends. Now, if we look at some of the research done in the Trump administration, there is predicted, right, an increase in the death toll in terms of up to 3,000 deaths a day by June 1st. is what has been reported, right? And we're going to see if this is coming to fruition, obviously. And if we look at other sources of research, in this case, looking at the IHME, which is the Institute of Health Metrics and Evaluation at the University of Washington, they revised their estimates up to 135,000 deaths in the US alone by August. Okay, and when we talk about obviously the impact there, we see that trend increasing and actually coming to fruition. This is the burden of the number of cases in the US as of last week. 80,000 deaths is where we were a week ago today. If we look at today, then where are we? We're at 1.5 million cases in the US and 90,000 deaths. So we are well on our way, obviously, by August, not just to meet, but perhaps surpass, if we continue the trend we're on, those projections from different organizations that we're seeing. So one of the questions we get often is, what is the burden of illness and mortality compared to our normal, right? Some individuals are have hypothesized, well, this may just be our normal death rate we see from the seasonal flu, right, or from other illnesses. And so this particular study and data looks at excess death rates in particular countries as a result likely of COVID-19, and they correlate that with those nations that have had, looking at those nations that have had increased outbreaks of COVID-19, obviously including the US. And the charts here you're seeing in the shaded areas represent excess deaths above and beyond the death rate that was baseline prior to COVID-19. And if we look particularly at the US, we are seeing the same trend, about 24% increase in death rates over and above our baseline. And so obviously there's still research that needs to be done to look at true causality, but there is some correlation there in regards to COVID outbreaks in those nations that have suffered in the mortality or the death rates in those particular nations. If we look at then again, kind of just the comparison of the U.S., how we're heads and tails above anyone else in terms of total number of cases, that trend continues, obviously, and the number of cases continues to grow week over week, right? But there is a little silver lining, if you would, in terms of if we look at the number of cases and increasing, our rate of increasing is continuing to bend, right? And if we look at then daily testing, how are we faring there? Last week, we showed figures of about 1.5 tests per thousand in the US. We're still there. We really haven't, and actually it took a little dip there, right, in regards to number of tests per thousand, but we'll continue to week over week pay attention to that number. And we'll compare now, this chart being new this week, and comparing our testing per thousand to other nations from a pictorial standpoint. And you can see we're kind of in the middle zone of testing per thousand compared to some other counterparts. If we look at then total number of deaths, how rapidly are the deaths increasing? This was this is as of today what the number of deaths look like in the U.S. In terms of trend over time. If we look at it on a daily basis, we can see a declining trend. This was back as of May 6th. This was the 13th. And this is today. So we're seeing a continued downward slope in terms of daily deaths. Obviously, that is good news. We know the total number of deaths is increasing, but the rate on a daily basis is going down. But how does that fare with regard to the rest of the world, right? If we look at then weekly deaths compared to the rest of the world, where we're number one basically, in that dark red zone there, if you see that. But then if we look at the trend, the rate, Are we moving in the right direction or the wrong direction? And if we look at this new pictorial here, we can see in the blue zone a negative growth of daily deaths. In the red zone, pink and red zone, that represents a positive growth, increasing rate of deaths. And so we are clearly moving in the right direction towards decreased rates of death. But still, the total number of death growth, the total number of deaths still increasing far above our neighbors, right? So what does that mean in terms of reopening your business, reopening your storefront, dealing with patrons and whatnot? How do we begin to articulate a best practice in regards to how to reopen? Obviously, different states, different governors are laying out roadmaps for reopening. The White House administration has laid out phase 1, 2, and 3 approach, but the roadmaps do have some commonalities, and they do have some gaps, and we want to try to fill those gaps and look at identify some best practices here by identifying some risk areas, if you would. So let's look at Maryland. They reopened not too long ago, and 4 days afterwards, this was just yesterday, reported their highest rise in coronavirus, right, after reopening. 1,784 newly confirmed cases, and that was, again, 4 days after beginning to reopen. And that was roughly, in terms of total number of people tested, which was 7,152, 25% of those tested positive for diagnosis of COVID-19. Right, and so that may represent, again, something we want to pay attention to in terms of trend of reopening. And obviously the question was out there, are we going to see increase in cases after reopening? This may be a leading indicator to that. And then if we look at then those areas that are reopening, in particular to Maryland, retailers, hair salons, churches, reopening at 50% of their maximum occupancy. So does that even pose a risk, right, is the question. We can answer that with this particular study that was reported by the CDC, looking at a case of a community church where 2 symptomatic people, one being the pastor, back on March 6th through the 8th, were present at 3 different functions at church. And during that period, they had 35 cases of COVID-19. 92 people attended those particular events, and 35 out of those 92 became infected, including 3 deaths, right? And so those are numbers, obviously, that we want to pay attention to as churches and different community-based functions and businesses begin to reopen, because we know where there is risk, because we've seen it and measured it, and it's going to be important that we continue to pay attention to these numbers and see how the impact of different measures are going to help decrease or stem the tide of these trends. Overall attack rate again being the rate of transmission of COVID-19 in this particular study was from 38% up to 78%, depending on how you look at the statistics. Obviously, still very high numbers, even at that low estimate of 38%. So other states obviously are reopening. Florida is reopening as of today, right? May 20th, they're beginning to reopen certain areas with 50% capacity. Okay, and so we obviously want to pay attention from an epidemiologic standpoint, but obviously more importantly, what are they doing in these places, right? They're instituting social distancing still, temperature checks as they begin to reopen restaurants at 25% capacity. And so these strategies, as we get deeper into the strategies of prevention that we want to look at, best practice across the pond here, this in particular is Disney, as they reopen in Shanghai and selling out tickets in a matter of minutes. When we talk about reopening, obviously theme parks being one of those areas where having thousands upon thousands of people not so much confined spaces, but all in one congregated area may pose increased risk. And so what are the measures that are in place that we can learn from that help mitigate these risks? So Disney, here's what they did. Required social distancing, obviously, so they decreased the amount of capacity in the park. They still held closed those areas in which there was high fomite or high contaminated surfaces, potentially, such as children's play area or areas where there are confined spaces and you can't social distance well. And then they also required, and this is a result of the structure in Shanghai, but they required everyone to have a QR code. And that QR code was tagged to your personal health record, right? And the QR code was allowing individuals to be either green or red in their history, meaning that if they're green, they're clear to go into the theme park. If they're red, they're unable to enter the theme park because of their health history, as it relates particularly to either travel or to infection or contacts. And so this was instituted obviously by a mandate, right? So we can learn from it because the number of people that had to participate in order to enjoy the reopening of Shanghai. And if we look at then and compare to what's happening here in the US, where you don't have mandated approaches to screening, we still have reopening occurring. This is Disney reopening in Florida. They're reopening not the theme park at this point, but they're reopening as of today their shopping areas, right, and their third-party vendors. And these are some of the measures they put into place. They've limited parking to reduce the number of entrances. They're doing temperature screening at the entrances as well. Anybody who screens higher than 100.4, not allowed in. They're requiring face coverings, physical distancing, so they're putting signs in place to require physical distancing. And then they're changing the operations of the companies and facilities itself to try to reduce the amount of traffic at particular times, right? So being closed at different times, allowing for increased cleaning of the facilities as well. So again, temperature checks, social distancing, physical distancing, capacity measures, face coverings, changing the cleanliness or paying attention to cleanliness, offering those hand hygiene opportunities with washing and sanitizers. And as we continue then to think about, okay, how do we take these these practices and inculcate them into a practice that it can be well-defined and can be instituted by our employers in a way that not just gives reassurance to employees, but also to the patrons that are showing up to your different facilities. That's what we want to offer and begin to think about. And so when we talk about that approach, we're kicking off an initiative internally with WorkCare, something we call COVID Clear Zone, right? And this is something that hopefully will be familiar to some of you all who are returning here and joining us again today. And it's an approach that, again, is consolidated in regards to how an employer addresses two areas, right? The employee on what we're calling tier 1 of the COVID Clear Zone, and then the patrons on tier 2, right? And so when we talk about the approach, it's pretty straightforward in that, and consistent with CDC, consistent with multi-phased approach in terms of screening, doing some type of pre-screening, for the employees in Tier 1, doing a site risk stratification, and then finally doing some type of surveillance program. And the goal here being a consolidated, comprehensive approach that allows the employees to feel less anxiety of coming back to work. But then as we get into the Tier 2 piece of it as well, we want to also have and provide risk stratification opportunity for patrons. We want to provide pre-screening for these patrons as well as on-site screening. Again, taking the best practices that we've been instituting with employers for months now, and then also learning from what's happening across the pond in Asia with regard to reopening and being able to offer assurances to a significant degree to participants. So what does it look like when the rubber meets the road? Hopefully this looks, again, familiar to most of you in that the screening process, again, we've been doing now for 3 months, is what's happening in these areas where reopening is occurring. Right, the red and green zone, the red screen and the green screen should be very familiar to you now. We were just ahead of the curve, thankfully, in getting these things in place with employers. And in fact, again, our employers that are doing this meet already many of that criteria that we're delineating as that COVID clear zone first tier. And then having a risk stratification for a particular location of operations is important, right? And we talked about this briefly last week or the week before, where we can estimate what the impact from the COVID-19 in your region or particular county would likely be amongst your workforce, right? 4.2 to 8% was this particular analysis that we presented previously. And then having in place a program that is comprehensive and rooted in surveillance, right? And where part of that obviously would be testing, not required, right? But obviously when it's available and these are the locations that we've already started testing, we want to make sure that we have those best practices in place as part of this comprehensive program and approach. And so when we talk about the COVID clear zone, this is what it's representing. That consolidated effort. Again, if you're already doing this as a partner of ours or doing this on your own, then again, we want to reassure you that you're doing the right thing. That there's nothing being done in areas where countries are reopening because we've started doing best practices again 2 months ago in some cases before reopening started to occur here in the US. When we talk about, as we wrap up here, the what the COVID clear zone looks like for patrons, I'm going to throw you a ringer here and say stay tuned because we want to give you more detail on this, but we want to hold it for next week so that you come back and we learn more and go deeper into what this looks like with consumers. And again, these are things that we've already rolled out, are rolling out with some of our customers in regards to having potentially thousands of people show up on a daily basis and having them participate, much like we saw in Singapore, in a process that gives reassurance to both employees and the patrons that people showing up have been screened, have been participating in a process that minimizes risk for exposure to coronavirus. So with that, thank you. We'll open it up to questions.
Thank you, Dr. Harris. That's really interesting. We can see Disneyland from the 6th floor of our offices in Anaheim. So it's interesting to see what's happening with that company in Shanghai. And it'll be interesting to see what develops there as the patrons return. So we have a number of questions as usual. I'd like to start off with one about behavioral health aspects of return to work and actual consequences of real fear about getting infected. There's a presumption that everyone's very anxious to return to work, and there's a pent-up demand, but there's also a flip side of those who really are reluctant to go back because they don't feel safe, which is an essential human need. What suggestions do you have for employers who are dealing with the behavioral health aspects?
Absolutely. In some cases, because of that anxiety, and will likely be the minority of cases, there are EIP program, employee assistance program, EAP, excuse me, employee assistance programs that are geared up and equipped to help and assist those employees that are having, let's say, significant difficulty coming back to work as a result of this pandemic. And we touched on that about a month and a half ago. We talked about some of the things that were going to be anticipated as we got into the strong social distancing and shut down parts of the economy. And a bulking up, if you would, of mental health services, and up to a 50% increase in some of those services that they were already seeing back then as a result of the increased social stress or psychological stress of what we're dealing with here in the pandemic. And then in a lot of cases, then that individuals are not experiencing that degree of anxiety. The programs that we are delineating to put in place with the employers are designed to give that assurance, right? And we're seeing that in those companies that have been doing the daily screening and whatnot for over a month and a half, 2 months now. We're seeing that anxiety level decrease amongst employees, and that's what we want to continue to double down on.
Okay, thank you. The next question is about a test, a specific test. The Abbott Lab COVID test got some bad press this past week regarding its accuracy. What do you think about that? And do you know how the Abbott test compares to the many other tests that are out there?
We agree that the data that we've seen on the Abbott test does not compare to some other tests that have a higher sensitivity and specificity. So at this point in time, we are not using WorkCare, the Abbott tests, because of that.
Okay, next question. Do you think the CDC will update its return to work protocols in light of the Korean study and maybe people, quote unquote, can't test negative?
We believe it's coming. I mean, in terms of the trend, we are seeing it anecdotally in the testing that we're doing already. In Texas, I spoke with a young man about a week and a half ago, and he, along with 60% of his cohort, tested positive for COVID-19 in the meatpacking facility. But when I spoke with him and said, hey, how you feeling? He said, I had a mild cough 3 weeks ago. Again, that's 3 weeks before he tested positive for COVID-19. His mild cough lasted 24 hours, and he was asymptomatic since then. So we know he fell into that group of continuing to test positive, but by all studies that we're seeing now, is no longer shedding the virus sufficiently to transmit. And so I think you will continue to see that trend. We'll continue to see more and more data point to that. And just as Korea did, we'll likely have some changes to requirements as a result.
Okay, that's interesting. This next question has a comment associated with it. It's regarding your data on death rates. There have been continued reports of reporting any and all deaths of COVID-related as a means for hospitals to gain anywhere from $15,000 to $30,000 per patient. How accurate is this statement? And the follow-up comment is, it's important to keep in mind that many doctors are being encouraged to code COVID as a cause of death without having a positive COVID test, because reimbursement is higher with a COVID diagnosis as opposed to influenza or influenza-like illness.
No, that's
so how does this affect actual death rates? Like, I guess the question really is getting to, are people really dying of COVID, or are people being pressured to denote COVID as opposed to an influenza-like illness because reimbursement rates are higher? And does that skew the data?
Right. I have not seen any studies that have looked at uh, or misincentives for coding in terms of the health practice for COVID-19. So I personally have not seen any data or know of any data out there that can substantiate that correlation. However, when we talk about looking at what we have predicted in regards to deaths from COVID-19, there is not a skewed number there in studies showing a increased disproportionality of deaths from COVID-19, which one could hypothesize if we were skewing the data to the right to suggest that there are increased number of cases of deaths from COVID-19. So we're actually seeing less deaths from COVID-19 than predicted in early models. And we shared those in previous webinars of studies that predicted 1.1 million deaths, even with social distancing in the US. So again, no data that I'm aware of that substantiates some type of disincentive, if you would.
Great. Next question regarding the Maryland data. The comment is the Maryland numbers seem to have increased not because of opening, but was already increasing. The question is, with an incubation period, how does 24 hours relate to opening cities if the test returns are not that fast yet?
So in that particular study, didn't look at the specific test and the turnaround time. We know that there are point of care tests that can produce results more quickly than several days. And so, and as soon as half an hour to 90 minutes. So it just depends on which tests are used. And yes, there does need to be additional studies looking at the cause of increased numbers for COVID-19. Although I pointed out the correlations don't necessarily mean causality. And so there needs to be additional studies to actually show that the reopening was the cause of increased cases, which there is no data to suggest or to strongly suggest that causality at this point. Correlation, yes. Causality, perhaps not.
Okay. Next question is regarding pre-screening when returning back to work. Do you think employees should be screened for COVID-19 on a monthly basis?
So our approach and guidance to employers for timing of testing in a surveillance type program is all predicated on relative risk. Meaning if you are low risk because you're in a geographic that has little impact from COVID-19 in terms of prevalence and incidence, then your testing regimen would perhaps look different from somebody who is in a geographic like New York or Chicago, where prevalence is far greater, incidence is far greater, and your relative risk may be greater as well. And so in terms of practicality of testing, it should be based upon risk, and the actual frequency may be monthly, it may be biweekly. We are not suggesting, and we would strongly suggest against a daily routine of testing or anything beyond a what we call a clinical that has clinical resolution. If the test would not change the actual outcome or behavior, then there's no need to test. And certainly testing at a high frequency like daily or even weekly perhaps may not impact your ability to mitigate transmission any far greater than biweekly or monthly.
We have time for a few more questions. If you can hang in there, Dr. Harris, we just have a few more to go. This one's about laboratory testing and clarification on whether a CLIA waiver is required.
There are a number of tests that a CLIA waiver can be used by a lab. CLIA being, for those who may not be familiar, CLIA is a guidance for conducting labs studies in the U.S. It stems from the 70s, in which back then physicians could test in their own lab, own facility, and there was little controls that resulted in a lot of disproportionate results. And so the U.S. incorporated guidelines for laboratories. There's 3 levels to CLIA. There's CLIA waiver at the bottom, then medium, and then high level for different tests that have different levels of complexity. There are a few tests out there that only require a CLIA waiver. Those tests may be like the finger prick test for antibodies, and then the majority of the tests available require a CLIA certification, not a waiver, certification of at least medium, and then a number of them require high complexity. So yes, CLIA waiver can be used for testing, but only for a select few of available FDA emergency use authorized tests.
Okay, thank you. I know it's kind of complicated because I looked into that when I was working on my FAQ. This is about cleaning the workplace. How many times per day should you be cleaning? Should you be doing it midday while employees are still on site? Which I guess would apply also to patrons who are entering your workplace, or visitors or contractors.
Yes, and so we're seeing cleaning regimens with employers that are multiple times a day, cleaning, 3, in some cases 4 times a day, the facility. And it just depends on the traffic, right? If traffic is high, cleaning more frequently would provide better opportunity to prevent fomite creation or contamination. Fomite being areas that contain viral particles, surfaces. And then we do recommend deep cleaning, and that's also recommended in literature in terms of at least once a day, doing a cleaning above and beyond just routine cleaning during the day. But certainly we are seeing cleaning while employees are at work, and we believe that is beneficial to do so.
Okay, we have time for one more question, and then those of you who didn't get your questions answered, will answer them in the written version. What is risk stratification as it relates to employees returning to work?
Yeah, so when we say risk stratification, we bifurcate that into their geographic risk and their behavioral risk. We call it the COVID risk appraisal. It's a survey of such that then puts an individual into high, medium, or low risk for potentially being exposed to COVID-19. And so again, geographic being the first piece of that. Are you in the middle of Wyoming, or are you in New York or New Jersey? And then behavioral, are you in a uncrowded area or a community setting where social distancing can be practiced readily, or do you frequent areas in which social distancing may not be as achievable? And that approach then makes up your risk stratification. When we talk about then organizational risk stratification, it means that location, relative risk because of widespread sustained community transmission in particular. And that's a county-specific reported designation, state and county reported. So there's kind of 2 approaches to risk stratification, the individual as well as the organization.
Okay, that wraps up our session for today. Thank you all for staying on the call and for your participation. We wish you all the best and take good care.
Thank you all so much, and stay safe.